All right, hello everyone. Good evening. I'm Jason Paragallo from Emory University, and welcome to the AAPOS Adult Strabismus Committee webinar. We're very excited today to discuss cases and the topic of complexities of Duane syndrome in adults. My co-moderator today is Manasa Indaram from University of California, San Francisco, and we have an amazing panel of strabismus experts, including Anne Languth from Northwestern University, Lurie Children's Hospital, Cami Gunton from Wills Eye Hospital, David Hunter from Boston Children's Hospital, Ramesh Kekunaya from LV Prasad Eye Institute, Hilda Capot from University of Miami Bascom-Palmer, and Federico Velez from UCLA. So the way this is going to work is each panelist will present their case. A discussant will discuss and analyze the case and give some comments. And then the panelist is going to finish the case and discuss the diagnosis and the treatment. And then if we have time, at the end of each case, the other panelists can comment. So this webinar will be recorded and will be posted for future viewing for you. So let's get started with Dr. Languth.
Thanks for having me. Begin by sharing my screen. All right. I presume we can see the screen. And for that position and discussion setting.
I don't see your screen.
So we have a 35-year-old male with a left Duane syndrome. Good. So he turns his head to the left for fusion.
Can you see our screen?
This has worsened.
We don't see your screen.
No, sorry.
And hold on, we don't see your screen.
No? We'll try again. Share. Is it going through this time?
Yes.
Yes, it's in edit mode if that's what you wanted. There we go.
Is it still on edit or in presentation? Hopefully presentation mode at this point.
Yes.
Yes, your audio is kicking in.
Yes.
You suddenly have a bad internet connection, but.
And why don't you turn off your video? That sometimes helps.
No. Okay. All right. Hopefully the audio is better at this point. So
yes, much better.
As you can see, this is a 35-year-old male with left Duane syndrome. This has worsened over time, and although it didn't bother him as a child, it's now impacting his ability to drive and perform his job as an auto mechanic. He has difficulty adopting head positioning while under and around cars. So as you can see from the sensory motor exam, he's clearly able to control his eye alignment in primary gaze, but to do so requires an approximately 15 to 20 degree left face turn, which he finds debilitating. He does have lid fissure narrowing and globe retraction with adduction of the left eye, and he does have a -4 abduction deficit on the left. So the main indication for surgery here is functional. The progressive head turn is interfering with this patient's daily life. And the surgical goal is not to restore normal motility, but rather is to reduce the anomalous head turn and to allow binocularity in primary gaze. In general, for these patients, I recommend you underpromise so that you can overdeliver. Patients should expect reduction of the head turn and not a normalization of motility. Alignment outcomes in Duane syndrome are generally less predictable than routine esotropia. Risks can include under or overcorrection, globe retraction. You might have up or down shoots that can appear if surgery is particularly aggressive. And expectation setting is particularly crucial for satisfaction. Postoperatively, we're going to be watching for alignment in primary gaze. Long-term, some drift can occur, and a subset of patients may still need prism or reoperation. Patient satisfaction is often strongly tied to improvement in their head position, though, rather than any sort of motility gain. Key takeaways from this part of the presentation would include that when you're operating for Duane, you might want to consider measuring and targeting the head turn rather than the deviation alone. And we can define success in terms of functional improvement rather than perfect motility. Additionally, careful pre-op counseling can enhance patient satisfaction. Surgical options that I considered for this patient were an ipsilateral medial rectus recession, a plus or minus contralateral medial rectus recession, could consider a vertical rectus transposition, partial versus full, or a combination procedure for a larger deviation. And now we could consider opening this up to discussion.
I think I get to be your discussant, Anne, and I wanted to talk to you about when you are considering surgical options. Do you base it on the amount of anomalous head posture, or I know there have been some studies that have said that, for head turns greater than 15 to 20 degrees, you want to have perhaps more than just the medial rectus because of recurrence of a head turn over time. So I'm just
Yeah, that's a
wondering
good question.
what your thought process is in terms of when you're considering a surgical procedure.
Yes, I agree with you wholeheartedly. So if it's over 15 to 20, that's when I would think about considering more than ipsilateral surgery or considering surgery for the head turn. In this particular case, for him, the head turn alone was why we were thinking of surgery. I apologize. I wanted to be able to turn on my camera to look at you, to be able to have a face-to-face interaction, but the internet connection went out again when I tried to do it.
I also just wanted to ask you about maximal medial rectus recession because of concerns of worsening globe retraction, limiting adduction in a patient who maybe has a type 1 Duane's. Do you have a certain number, or do you feel that intraocularly? I'm wondering how you kind of approach that.
For me, I would oftentimes try to do it based on ductions. So although we might think of a maximal number on a table, oftentimes, at least in training and what I found, and there's the titans of the field here, but it kind of seems like you get a sense of where the muscle wants to go and where the muscle's comfortable and where the muscle
I'm so sorry, Anne. It seems like it's breaking up again with the audio. But from what I understood, it's you base your decision based off of forced ductions and kind of where the muscle wants to land once you remove it from the globe. Is that correct? Oh no. Okay.
I think maybe we will have to move on and let
Yeah.
Anne finish up when she rejoins.
Yes. Okay. What we'll do is we'll actually move on to our next case and then come back and we'll leave it in suspense for what actually ended up happening with that case until we discuss our second case. So next up, we have Dr. Cami Gunton from Wills Eye Hospital, who will be presenting yet another challenging case in Duane syndrome. Cami, you're muted. Sorry.
Sorry about that. I apologize. Thank you so much, Jason and Manasa, for allowing me to participate in this really cool adult strabismus topic. My case is, I think I've kind of given it away a little bit, torsion and how much I hate torsion. So let me get right to it. I have no financial disclosures regarding this presentation. So it's a 56-year-old female with a history of type 1 or esotropic Duane syndrome in her right eye. She'd had a face turn for years and had multiple prior surgeries as well. these were done in elsewhere. She came in with myopic glasses, no prism in those glasses, but her main complaint was a significant face turn. Her past surgical history, we were able to find out that 20 years prior, she had had a right medial rectus recession of 5 millimeters, and then recurrence of her esotropia. And then 8 years prior, the medial rectus on the right eye was re-recessed to 8 millimeters from the insertion or 13 millimeters from the limbus. And then that only lasted for about 3 years. And then 5 years from when she presented to me, she had her contralateral left medial rectus recessed as well. When I saw her, she had a good face turn, 15 degrees, and was actually coming in complaining of neck pain, good visual acuity, no amblyopia, 20/20 vision in her glasses. I did check to make sure that there was no accommodative component, just made sure that she was not over minus. Her motility exam showed classic narrowing of her lid fissure and adduction. I put the patient in primary and try to measure. I usually, just to get a sense of, am I getting the face turn correct, because I don't always bring out a goniometer, sorry about that. And it was about 30 prism diopters. The right eye was only able to get to the midline, no abduction past the midline in the right eye. Surprisingly, even with that big medial rectus recession, she still had full adduction in the right eye, no exotropia in left gaze. There were no upshoots or downshoots, and there was no vertical deviation. And unfortunately, I did not measure to see if what her torsion status was prior to surgery. So I didn't do a double Maddox rod then. So I wanted to talk about what the surgical options would be at this point. I think this is what I was thinking, and I would love to hear Dr. Hunter's opinion, especially because he has written the book on this. So you could recess the medial rectus, but it's already recessed, and I need a big effect. I felt 30 prism diopters worth. I think that this patient should have a transposition. So would you want to do just a superior rectus transposition, augment it, do a myopexy that's a loop myopexy, or scleral fixated augmentation? I have not done Nishida's for Duane's, but that's another possibility. And then you could do both vertical muscles transposed. So I guess, Dr. Hunter, do you have any comments for me at this point?
Oh, I might have a few, yes. And just for full disclosure, I did receive I did see you had sent your presentation and I saw what you did. So, but still, it doesn't change my thoughts on what I would do. I think that, the first observation is that I'm really surprised, like you were, that the adduction of the right eye was still full. And you had said it was re-recessed to 8 from the insertion or 13 from the limbus. So I don't believe that it's actually there. I suspect that when the time comes to do surgery, that the medial rectus muscle probably isn't as far back as you think. And I probably would explore just to really confirm that it's that far back, because any sort of transposition might create an exotropia in left gaze. And that's also referring back to the first case. Like you want to try to avoid as best possible creating an exotropia anywhere, but anticipating that you might get an exotropia in the opposite gaze direction, I'll usually put up a prism for the primary gaze deviation. So in this case, I'd put up a 30 and then have the patient move her head to the side and demonstrate what it's like to see double in a place where she has never in her life seen double before. I guess in left gaze, in right gaze, it's left way. So
It's right ways.
and Sorry. I really don't ever recess back to the first case more than 5 or 5.5 millimeters on Duane patients, because they can be so miserable when they get overcorrected. So I thought it was insightful for you to check that she's not over minus. That's not something we always think to do, especially in adults who have strabismus, but I've seen it. Definitely seen over minusing and actually saved patients from surgery by knocking a 0.75 diopters off of their prescription. I did want one other thing. One other reason maybe her adduction is full is the lateral probably isn't very tight. Sometimes the lateral tightens up in Duane syndrome, but since there's no upshoot, that's probably the case. So anyway, that's all a preface for what would I do. And I almost never don't do a transposition in Duane patients. It's always, to me, disappointing to see you move the medial. Yes, you can more or less get the head straight, but then you just don't get any abducting movement whatsoever. And if you can even get the from -4 to -3, patients really appreciate that. And while it is riskier and it's a little bit harder to do, it's just such a better outcome that it's worth the risks. Now, in this case, I debated if the medial is that far back, would I actually pull that forward as well? And I was thinking I might consider doing that, but one way to mitigate against having to do that is I would probably just do a transposition, but not put an augmentation suture on it because I don't know that you would need that much effect. And then I would also, whenever I do my transpositions, I never know if I'm going to get a hyper or not for sure. So I always put it on an adjustable suture, the little short tag adjustable, so that if the patient does wake up with a hyper, I can let it out a little bit. If they wake up with a hypo, I can't do as much, but that rarely happens. It seems like more often than not, it's a hyper of a couple prism diopters, so I'll just let that out by a little bit. So I would explore the medial, just see where it is, prove that it's actually 13 or wherever it is from the limbus, and then do a non-augmented adjustable lateral transposition of superior rectus muscle.
Well, that sounds really good. In my defense, this was a case many years ago. I just reviewed papers that you and Dr. Doggy had written, and yes, there may be less vertical tropia in a superior rectus, and that there's an improvement in abduction with the superior rectus transposition, and recurrence of ET may be less. So I had decided I was going to do a transposition. I don't do adjustable sutures very often. I was clever enough to mark the 12 o'clock position on the cornea, 12, and now I know I have to actually mark 12 and 6. And I love Dr. Doggy had written in a paper, mark it onto the lids, so you can kind of see the whole thing. At that time, I didn't. I just marked it 12 o'clock on the cornea. I thought I was being clever, but I wasn't, because when I transpose the superior rectus, I do a full tendon transposition. I put it at the border of the right lateral rectus, following what I think is the spiral of Tillot. And I did do the augmentation suture. I thought I would be okay because I wasn't going to put a scleral fixated. I was under the impression at that time, because I hadn't read all of your papers so carefully, that it doesn't matter if you do a loop or if you do scleral fixation, you can still get verticals and torsion. But nevertheless, at 8 millimeters posterior, I put a Merceline loop myopexy. And the patient woke up, and immediately there was no face turn. It was all gone. And she could abduct the eye. It was amazing. I know I've done superior rectus transpositions now more, and I've seen it. It's very nice to see actually some abduction. She had a right hypertropia. It wasn't large. And yes, I got that exotropia that Dr. Hunter said I would. But the thing that was all that I thought we could deal with. She was wearing glasses already. I could do a little prism. We could do this. But she had 7 degrees of encyclotorsion. And as Dr. Hunter mentioned, these patients fuse all the time. And now there was no position that she could fuse in. She was absolutely miserable with me. And that brought up, okay, I didn't have an adjustable suture on it. No prism made life happy. Should I wait? Does torsion like get better. Like, some of our strabismus gets a little better. I've actually seen hypers when I do transpositions they just kind of disappeared, or the patient was able to fuse them. And it became not as problematic. But this patient is really unhappy and she's an adult. And then there was, how much should I take down? Should I just cut the Merceline suture? Or, as Dr. Hunter had suggested, do I need to kind of recess? And now should I put the superior rectus on a adjustable suture? So those are some of the things I talked about. And I know I don't want to run out of time for people. There are wonderful papers on this now. So hypertropia is reported in 8% of cases, and in looking specifically at Duane's, there's a huge group published out of Boston Children's. 37 of those patients had Duane's, and no patient had symptomatic torsion. So evidently that didn't work for me. But in a paper where they looked specifically at torsion at UCLA, they noted that there were 1 to 8 degrees of encyclotorsion induced when they measured them preoperatively versus postoperatively following a superior rectus transposition with myopexy. I'll just stop right there for one last question about do you wait or do you not wait, Dr. Hunter?
Yeah, no, I think you're already 2 weeks out and she's still really miserable and seeing the torsion, and she's exotropic. So yeah, no, I think it's reasonable to go back.
Yeah, I actually looked at my notes and I probably did say 2 weeks, but specifically it was 10 days. I guess I couldn't last the 2 weeks. I decided to cut the Foster suture. I was surprised that it was so easy still to cut. Sometimes I find scarring afterwards, but it's pretty easy to find. I cut it. And I think the thing that made me decide not to put the superior rectus on an adjustable was that it just kind of separated. Like you could just see the two like go, we don't need to be together anymore. And I just thought that was great. So I left the transposition as it was and kind of did a little small prayer, and it worked. The torsion resolved. She no longer had symptomatic hypertropia, but the abduction that I had achieved went away. She only was able to get to midline. Her face turn was still significantly improved, but it had returned by a little bit as well. I thought it was an acceptable amount. So I don't know if you have any other comments, but that's the end of my presentation. All right, well, thank you so much.
Yeah, no, and you would only put that back 8 millimeters for the augmentation, but still, that's still a lot. So I think there was a helpful comment in the comments, Dr. Guyton suggesting another option would have been right lateral rectus, left, whichever eye it was, the lateral rectus resection. If the patient didn't have significant globe retraction, I can't remember if she did, that would be something to consider. But I wouldn't do it if she did have a lot of globe retraction.
She didn't have significant, but she did have narrowing of the fissure. And I never know, I don't want to make it significant, I think is my concern. Yeah. Thank you.
All right, thank you. I think we're going to move on to Dr. Hunter's case next.
All right, very good. Let me just set this up a little bit here. And just having fun with the computer. Okay. There we go. All right, so one of the interventions you suggested was a vertical rectus belly transposition, aka Nishida. I'm not very good at remembering eponyms, so I want to talk about a case that I saw, and Dr. Kekanai is going to discuss this case. So the patient presented to me increased double vision after surgery. She's 24. She's a mechanical engineer. Duane syndrome early in life and had bilateral medial rectus recessions, unknown amount when she was 8 for ET at 25. And then a year ago, before presenting, the left eye started crossing again. She presented to an outside surgeon, ET 9 at that point. And so then 11 months before presenting, she had vertical rectus belly transposition. This is from the other surgeon's records I was able to get a hold of. So vertical rectus belly transposition, where you see the drawing here, plus Botox 10 units to the left medial rectus muscle. So She was overcorrected. 6 weeks post-op, XT45, LHT10. She was having diplopia. She wore an eye patch for 5 months, waiting for the Botox to wear off. Still exotropic after removing the patch, still diplopic, now turning her head to the right, but she has no left gaze and not much right gaze either. So the eye movement's worse, and now she's got a new upshoot that she never had seen before when she looks to the right. And she has new globe retraction that she had also never appreciated before the surgery. So on examination, you see that she is XT8 in primary with a little left hyper. She's 20 in right gaze, the left hyper builds. She's got this +3 upshoot with the left hyper going up to 16. In left gaze, though, she still has -3 abduction, ET16, LHT8, and also has, although it doesn't measure, we thought that it appeared that she had a -2 introduction of left eye. Minimal refractive error, right head turn, 5 to 10 degrees, and then 3 millimeters of anophthalmos or globe retraction on the left, but good stereo when she holds her head in just the right spot. So in summary, 24-year-old woman, Duane syndrome. Now she has exotropia, left hypertropia, globe retraction, and upshoot after a vertical rectus belly transposition. So what do we think happened and what do we do now, Dr. Kakanaya?
Thank you, Dr. Hunter, for that interesting case. I think first look at what exactly happened. I think the patient had 9 prism diopters of esotropia when the patient presented to the surgeon elsewhere. So we do not have any information about what are the retraction and other things. So for a 9 prism diopters, a transposition of both the vertical rectus muscle, even if it is belly transposition, with the 10 units of medial rectus botulinum toxin is too much. What happens is the botulinum toxin itself can paralyze with that much amount, the medial rectus. And in the immediate postoperative period, the force with which transposition has been done, that can pull the eye out. I see that over a period of time, I think 45 XT, which is expected in this particular case if you do this procedure. I see that when the patient is presented, it came down to, I think, 12 or something in the primary position with the vertical, 8, not 12. On the right gaze, she has 20 prisms. And in the right gaze, the hypertropia is more. This is something very, very unusual. On the left gaze, the hypertropia is less. So there is some imbalance between. So what happened? My guess is that the surgery and the pharmacological treatment is too much in this particular case. What could have been probably done easily at that stage? Again, I do not know the other parameters. Probably one muscle re-recession, or if there is not much of retraction, probably a lateral rectus resection. Dr. Kraft has a beautiful paper on this. That could have been saved this. But now, what do we do? Probably, I would have done my first priority in consecutive exotropia, after looking at so many cases over a period of time, is touch the lateral rectus. But in this particular patient, the lateral rectus is already, bound by the vertical belly of both the muscles, and it's already, I do not know how many days or how many months after postoperative period. If it is immediate, probably you could have cut that. That could have been. But here, especially on adduction, the exotropia is more. Probably I would advance the medial rectus, but with the caveat that there is a vertical thing. So I would still explore the area of the vertical belly transposition. If there is any shift of the muscles, if I can see clearly without any too much of a scarring, I would cut one of those, probably the superior rectus, and then do a little bit of medial rectus advancement. Again, This all depends upon the intraoperative examination and the force duction test. Based on that, we will do the surgery. Let's hear what Dr. Hunter has done. Thank you.
All right, so I was very concerned that this rectus belly transposition was too much, like you said, and and in fact, that the medial was now so stretched out that even taking it down might not be enough. But I first wanted to just reset, take down that vertical rectus belly transposition and see what happened. So that was my thought going in, although I did consider doing more surgery. But then once I got there, this is my professional drawing. The superior one was 13 back and about 5 millimeters above the left lateral rectus muscle. The inferior vertical rectus suture was also 13 back, but it was more than a lot more than 5 millimeters away. So it had ended up being an asymmetric transposition. The superior oblique is over here, sort of involved, but just kind of stuck to the muscle. And the medial was not tight, even though it's often tight in Duane syndrome, but the left lateral rectus muscle was tight. The superior oblique, the exaggerated traction test on the superior and inferior obliques was actually normal, even though there was this involvement. So considering all of this, I decided these were Prolene sutures. I just cut the Prolene sutures, and then I didn't just wait for it to go back. I put a little hook under there to reposit the muscles back to their original position. And I figured that 10 units of Botox, the 40 prism diopters of XT for 5 months was going to be enough to sort of stretch things out and treat her, and it should be enough. So so that's what I did. And so 2 months post-op, it was just a virtual visit. So apologies for your vision's not going away. It was on her phone. It was a tiny little thing, but I did the best I could with it. So she had a slight increase in her range of motion, she said, and improved head turn, but still was noticing the globe retraction, which she said was new, and the upshoot and adduction, which she was sure wasn't there. So this is remote, but I scheduled her for another surgery if it wasn't better in another couple of months. So that would have been 4 months then post-op. So we were targeting having her come to town, on a Thursday, surgery on a Friday, if it didn't look good. So she comes in 4 months post-op, day before her surgery schedule. She's ortho in primary. She has good stereo, still a little right head turn though. So maybe she's not entirely ortho, but ET 25 over there and still XT in right gaze. And she's super unhappy about that. She's unhappy about this +1. She's unhappy about the left hyper over there. She used to have much better range. Her range of motion is still smaller than it was before surgery, and the globe retraction is bothering her. So, against most people's advice, but she really wanted it fixed, I brought her back to the OR and and I found that the left lateral and medial, I swear the medial wasn't tight the first time, but they both felt tighter than normal. I found that the medial was 11 from the limbus, so no room. You certainly wouldn't let that out any further. So I recessed the lateral rectus muscle with surgeon's view. It's the camera wasn't really working right that day, so I don't have good video. But recessed the lateral with a Y split, putting both poles 3.5 millimeters back, figuring, well, she might get a little ET in primary, but that's how she was most of her life, so she can live with that. 1 hour post-op, E2 in primary, but still adduction was limited from this tight lateral rectus muscle. So I put the poles back another 1.5 millimeters to bump it up to 5. And at the post-op adjustment, she was E4 in primary, down to XT2 in right gaze, ET not too much bigger in left gaze. And then, so 3 days post-op, she was perceiving better range of eye movement, better range of binocular single vision. You see the XT is down to 4. There's no hyper anymore. The ET is 35 over there. Exophthalmometry, the globe retraction is better. So I did not adjust her further on post-op day 3, though I could have with the short tag adjustable. So 2 months post-op, we're back to virtual visit. So I apologize, I don't have any measurements beyond day 3, but her head's straight. There is some globe retraction, but it's much better, and she had no concerns. So she was happy with this result. So I have found, so vertical rectus belly transposition, I just want to cite this one article by Yao where they compared it to my preferred superior rectus transposition. And they found that it actually was more powerful, 66 prism diopters of effect versus 51 when you combine it with a medial rectus recession. But I have used it a few times, and I don't think it's the right thing for Duane syndrome because it exacerbates some of the restriction. It can worsen the globe retraction, and in my experience, it can sometimes limit vertical gaze. So I don't even always use it in a 6 nerve palsy unless it's profound and generally bilateral. I will use it sometimes, but not in adults who have acquired 6. So I don't recommend this for Duane syndrome, and use carefully in 6 nerve palsy. So the lessons learned from this: avoid causing adduction limitation in adults with Duane syndrome. This vertical rectus belly transposition is strong, but it can worsen globe retraction, even in non-Duane syndrome eyes I've found. And the delayed adjustable allowed me to operate on this orthotropic patient and still make her better. So I will turn it over if anybody wants to for further discussion. Stop my share. I was going to stop my share.
Thank you, Dr. Hunter. I think in the interest of time, we'll move on to our next speaker. Next up, we have Dr. Ramesh Kukunaya, who's from LV Prasad Eye Institute.
Thank you. So I'm going to present this case, caught in retraction, a surgical mystery of miswiring and fixation. So he's a 33-year-old male. He hails from Hyderabad, India, comes with the face turn, saying that he's not able to move his eye, and there is a smaller appearance of the right eye on looking to the left side. And he came for some kind of surgical opinion. And he also had a syndromic association. As you can see, he has a hearing loss, mild right-sided. And you can also see this ear tags, which you can see sometimes in patients with Duane syndrome. Vision-wise, he's okay. With the head turn, his stereopsis was 70 seconds of arc. Color vision and other things were normal. Anterior segment again showed this lipodomoid with the syndromic association, and the posterior segment examination was normal. We really could not take the picture in terms of looking at the torsion. And this is his extraocular motility in terms of when we put him on the primary position, he is taking up this. I will also show a quick video. I hope it is seen. So there is a significant retraction, and both abduction limitation is more, and there is a kind of pumpkin seed sign. It just disappears. The complete cornea disappears there. He has, if you look at the translucent occlusion cover test, if you can see with the left cover and the right cover, it's different, and he is extremely bothered about this upward shoot. And this is his measurement. When you put it on the primary, it's so difficult to measure because if you look at this picture, the right hypertropia looks much more than 3 prism diopters. And on the left, the right gaze, his esotropia is increasing. And that's what it is. And, on looking to the left and even in primary position, his cornea is not seen. It's definitely very, very concerning for him. I would like to hear Dr. Hunter's opinion, or I don't know, Dr. Hilda Capo, I think. What would you do at this point of time? What is your choice? And he would like a surgical correction, and he's not wearing any glasses or other things. Dr. Capo,
Okay.
sorry about that.
Oh, no, a pleasure, Ramesh. And sorry, you're not getting Dr. Hunter, but you're getting Dr. Capone. Anyway, it's an interesting case. I think he's like a type 3 or mostly orthotropic Duane syndrome on the right eye. However, he does have a small ET, but he prefers a little bit of a left face turn, kind of suggesting more like a little bit of an XT in primary position. However, primary position, the last thing when we see patients like this, several things that we need to determine first, what are the patient's expectations? What does he want? And what are the goals of our surgery? As was mentioned before, we were not going to give him full motility, but I assume that his main concern is that upshoot that is pretty significant. He does have stereopsis, so there's always a risk of inducing diplopia. I don't think he will suppress because, again, with such great stereopsis, diplopia may become very bothersome, and we've seen cases in which that has already happened. I think forced suctions in the operating room are always very important in terms of to decide what muscles to operate on. But with this kind of deviation and that large offshoot, I think I would probably recess both the medial and the lateral rectus muscles. Usually, if they're exotropic, you do more resection on lateral. If isotropic, probably a bit more in the medial, but I think I will recess them both. I would probably do a wide splitting of the lateral rectus muscle to try to control the offshoot. And again, I would probably will not do any vertical rectus transposition initially, because I think the main concern is the offshoot that he has. So I think that's the way I would address this patient. It will be interesting to see what you decided to do for him.
Okay, I would go on to, what I did. Obviously, these are the concerns of any patients with Duane syndrome. If you look at the cartoon, I borrowed it from Dr. Stephen Kraft from Canada. You have to look at the alignment in primary position, adduction or abduction limitation, presence or absence of globe retraction and its grade, and also grading of overshoot. Additionally, if you look at this particular patient, he had significant overshoot and retraction. So this is what he is. He is closer to ortho. There is a significant abduction limitation and also limitation of adduction. Overshoot and retraction are significant in this particular case. I would also add to this two more things. You have to check the FDT intraoperatively, and presence or absence of bands and also laterality matters when you really have a surgical plan. And from a patient's point of view, you also have to take care of, binocular single vision field, all that you need to take care. So intraoperatively, if you look at the FDT, if it is tight, probably a medial rectus recession. And for the globe retraction, what are the choices? You can do a asymmetrical horizontal rectus muscle recession or a periosteal fixation. For the overshoot, either you can do a lateral rectus recession with or without Y-split, depending upon the grade of overshoot. So here it's a lot. And also you can do a periosteal fixation. So what we did a periosteal fixation because of the lateral rectus muscle. I hooked the muscle on the lateral rectus. You can see it just slipping. We also did the medial rectus recession. So we use this larger, suture for this periosteal fixation. Once you disinsert, I remove the drape, and then, one of our oculoplastic consultant, Dr. Milind Naik, he taught us this technique where without even opening from inside, you can make a small opening in the skin and then pass this lateral rectus through and through. You have to have a perception of the periosteal, fascia, and then fix it and do a suturing of the skin with the vicryl there. I also did a medial rectus recession because when you do this periosteal fixation with the isotropy of 3 or 4 prisms in the primary position, it can cause a lot of esotropia. So this is his post-operative picture, video, in fact. One of the problem it created is the abduction limitation. So fortunately, he does not have a new diplopia. This is something we will have with this particular technique. The overshoot is gone. The globe retraction is gone. In the primary position, he is still ortho. We could maintain an ortho position in this particular position. Thank you very much. And if there are any comments, we can take from others.
Well, I think you had amazing results, so we cannot say anything against that.
Yeah, it's a fascinating case. Yeah, thank you so much, Ramesh. I think, oh, sorry, Dr. Hunter, you had a comment.
Well, if there's time, do you think you still could have gotten away with just a large recession and a Y split to give you a chance to preserve a little bit of abduction and still reduced it? This patient was okay with it, but I've had other patients not okay with it.
Any patients who have a combination of grade 3 and above, retraction and overshoot, we have seen the lateral rectus recession. Unless it is beyond 10 millimeter with the Y split, it might work. But when you do a 10 millimeter of recession, it causes similar amount of abduction limitation in Duane syndrome, what I get with periosteal fixation. So I have changed my practice. Whenever the grade of retraction and overshoot is beyond 3 plus, probably single muscle lateral rectus periosteal fixation works. So this is what it is. But can you get the similar results? Yes. But the abduction limitation is almost similar there as well. Thank you, Dr. Hunter, for that comment.
Thank you, Dr. Kanaya. We're going to move on to Dr. Kapo's case next.
Can you see my slides?
Not yet.
Okay. Yeah, you should be seeing them. Let me try something different. You don't see them yet?
Not yet, no.
Okay, let me try this. Okay, my apologies. It tells me that it's invalid to start it. I'll try again.
We can see your screen now.
Okay, perfect. I just don't see it where it should be, but that's okay.
But you haven't started your slideshow yet. It's edit mode.
Okay, that should be good now, right?
Well, now it's in
Okay.
presenter view.
Okay, let me just swap. Okay, that should be good there now.
Perfect.
Okay, great. Okay, well, thank you for the moderators who invite me to participate in this webinar. I think the AAPOS Adult Strabismus Committee webinar is always one of the best. I may be a little bit biased though, but thank you again for allowing me to participate. So my case is a 38-year-old man who complains of right eye drifting out. This started at birth and it's a constant deviation. He has a left face joint and he's unable to adduct the right eye. So visual acuity is good in both eyes, and external anterior segment examinations are remarkable, so is a fundus exam. So you can see he has a significant left face turn, probably about 20 to 30 degrees. In primary position, he has a right exotropia of 30 to 35% diopters. with significant limitation to adduction of that right eye and my limitation to abduction. He doesn't have stereosis, but he has some degree of fusion because when we place the prisms, if we go over 35% diopters at distance or over 40% diopters at near, he complains of double vision. So this will be an important consideration when planning surgery for him. So this is his motility exam, is the video. And you will notice that he does have significant overshoots, both upshoot and downshoot, similar to the case that Ramesh just presented. There are mechanical limitations. Interestingly, he has a little bit of a adducting nystagmus on that left eye, and the fissure narrows a little bit when he adducts the left eye. But his main problem is the right eye, and you will see the upshoots. There's a downshoot there when he tries to adduct the right eye, and it's slightly below midline. And again, we'll see the upshoots and downshoots very soon. So there you see the significant upshoot, and this is very typical for the mechanical upshoots and downshoots secondary to a tight lateral rectus muscle. Again, this is a patient with his face turned. He has a very small intermediate XC there, and he fuses in that position of gaze. So he's really bothered by his face turn. In the primary position, there's a larger deviation. He cannot really adduct that right eye all the way to midline. In terms of retraction, he has severe globe retraction as well. You can see it's a grade 4 globe retraction. Pretty severe, and that was also bothersome to the patient. So we already talked about goals of the surgery in Duane syndrome. Ideally, we'll improve the deviation in primary position, improve the ocular rotations, even though this is not always possible. Importantly, correct the normal head position and minimize the globe retraction and overshoots. In adult patients, we need to be aware of the risk of diplopia and what the patient expectations are. In mild cases, we can do conservative management, but none of the cases that we're showing here are really mild cases. So what are the options for an exotropic Duane retraction syndrome? If it's a small deviation, 20% diopters or less, usually one lateral rectus recession may be enough to treat it. If it's larger, you can do bilateral lateral rectus recessions. You may consider doing asymmetric recession with a larger recession in the contralateral eye. We already mentioned how important it is to try to prevent worsening of the abduction in the affected eye, even though sometimes it is necessary to sacrifice abduction to accomplish our goals. Either we have significant overshoots. We already mentioned large lateral rectus recession with a wide split. Keep in mind that splitting and suturing the muscles will tighten it, so it requires an additional recession amount than what you would have done otherwise if you were not splitting the muscle. And if you have a large exotropia with significant overshoots and retractions, you can do a large lateral rectus recession with a wide split. You can do the lateral rectus periosteal fixation that already Dr. Kekunaya described. If it's going to really cripple the abduction, as we have seen, if we wanted to preserve, you may want to consider a vertical rectus transposition to the lateral rectus muscle to improve the abduction and decrease the risk of consecutive esotropia. In the previous case, we saw that instead of doing vertical rectus transposition, it was addressed more with medial rectus recession to balance the periosteal fixation with recession of the medial rectus. So I would like to know with my discussant, Dr. Bellis, what would you do in a case like this?
Thank you, Hilda, and thank you all of you in the Adult Strabismus Committee for inviting me to be here today. Very interesting case. I will say that I have seen a lot of patients with exoduanes, and the first thing I look at it is that for your patient is specific. Your patient has really poor motility. There's kind of a little bit of a simultaneous divergence type of a movement, not typical, but your patient couldn't really move the right eye past the midline at all. So what I'm finding very frequently in patients like this, beyond what you already described nicely there, are three things. One, you have to look for accessory fibrous bands in every single exotropic Duane syndrome, especially if there are no females, and especially if it's the right eye that is involved. Because on a small series that we presented at AAPOS a few years back, that's what we found, that it was actually quite common in non-white male right eye. Arif Khan actually has published a couple of cases that had genetic mutation on COL2A1 that actually have simultaneous divergence. And there is a good paper at Orbis that describes this as Duane type 4. So that's one thing that I will definitely look in your patient, no question about it. Second, I have found patients in whom I did exactly what you described and they were undercorrected. And I had to go to the medial rectus later and do a medial rectus resection because there is some evidence that the medial rectus can be underacting in patients with Duane's, perhaps because some of the innervation that was going to the medial rectus muscle and now going to the lateral rectus makes the medial rectus muscle underacting. I actually saw one patient that the medial rectus was very atrophic. Intraoperatively, we have to actually do a medial transposition of both vertical rectus muscles to actually finally cure his exotropia. So that's my third point, that if the medial rectus resection after you did a large lateral rectus resection doesn't fix your exotropia, I highly recommend you consider doing a medial transposition of the vertical rectus muscles for a patient with these large angle exotropias. But other than what you describe over here, and I agree with your last point, because I mean, if you're going to kill the abduction, why not to give abduction by doing a transposition? The problem is that if you do it simultaneously and you didn't assess the medial rectus muscle function, maybe by an MRI or just looking at it, you may have a big overcorrection, which has happened to me as well.
Okay, so I usually try to keep it very simple. So I ended up doing the recession of both lateral rectus muscles. And this was a patient before the adjustment. I decided I'll place them both on adjustable sutures. I want to play it safe. And the patient, I don't know if you can see, we could have to cover his mouth, but he was super happy, smiling because his head was perfectly straight. He did have a little bit of double vision and it bothered him. He had about 6 of esotropia and he did not want that double vision. So I advanced the right lateral rectus about 1 millimeter. So that day of the surgery, he was perfect. He was ortho at distance, a small XC at near, no diplopia at distance or near, and his head was perfectly straight. He came back day 1, and he had pretty good, you can see, there's a little bit of, actually this was the day of the surgery. You can see a little bit of limitation of abduction more than before. His low retraction has improved. He still had pretty good adduction now. Actually, adduction has improved significantly. And there's just a slightly more limitation to abduction. Again, you can see the kind of anomalous movement in the left eye when he does adduction. So patient was super happy. I was super happy. He was no double vision. He's doing great. Pretty good motility, improved adduction with only slightly worse abduction. He came back on month day 2. He was still pretty good, very small XT, doing great, patient happy, no diplopia. He comes back 2 months later, and he developed a small recurrence of the exotropia. And you can see the face turn, not as bad as preoperatively, but his face turn has returned. Now he has some improvement of the abduction and worsening of the adduction with worsening of the globe retraction. So I thought it was kind of interesting that these patients tend to, again, the lateral rectus recovery function had a recurrent XT. When we deal with patients with Duane syndrome, isotropic Duane syndrome, it's usually the opposite. They tend to be overcorrected, so we're more concerned about that. So what next? I have several options. He was so happy initially after the first surgery. I may go back and recess both lateral rectus muscles and probably aim for a small overcorrection. I don't know what the experience of the other panelists has been, but I think I may try this before going on with a transposition again, because he was really bothered even with a very small dystropia immediately after surgery. Any comments, Federico?
Well, I just go back to what I just told you because I've been in situations like what you described. Honestly, I mean, you can revise the lateral rectus. It's usually very tight. And now that it's been recessed, it usually looks like it's tighter. Again, I will definitely look for any accessory extraocular fibers, muscles, or whatever you want to call them. And to be honest with you, if you can move that lateral rectus back more, I will go and look at the medial rectus. I think that, in my opinion, will be, I mean, you can put the lateral rectus to the orbital periosteum if you think that will last longer. I always feel like Ramesh presented a very nice case, but my experience, to be honest, is that no matter where you put the lateral rectus, you recess it or you put it to the orbital periosteum, the globe retraction and the limitation to a deduction is always there. I mean, there's no question that you still have some of that. And even in your patient after the recession, there was still globe retraction. Absolutely, you improve initially the motility, and the patient was kind of a little bit passing the midline. But I think your lateral is tight. Go back, explore the lateral again.
Yeah.
But you have to do something medial to hold that eye straight, honestly.
Yeah, maybe we'll have to tighten a little medial. I just don't want to, his globe retraction is so severe that I was trying to avoid a resection. But I think there's room to recess the lateral rectus, and I agree with you. I think I'm going to go back and it's going to be very tight. So I hope that helps him. Again, he's motivated because he has such a wonderful result immediately. But
Right.
the recurrence of the exotropia, again, that lateral rectus is still tight and tighter than the medial. So I know take-home points, I think it's so easier to do lateral rectus recessions, and we avoid problems with vertical deviations and torsions that we can see. Alignment and globe retraction can be significantly improved. And again, I wonder if we do these lateral rectus recessions, so we should aim for overcorrections due to the recurrence that we saw. Thank you for your attention.
May I make one comment?
Sure, go ahead.
Take too much time, but I think it's really important in the exotropic Duane's patients to an adjustable FODN on the contralateral lateral rectus muscle. It reduces the abduction slightly, and it takes a little bit of pressure off of what you have to accomplish in the Duane's eye, because you're never going to get full adduction, no matter, whatever you do in the exo Duane's eye, you're just not going to get full adduction. And so if you can take a -1 off of the other lateral rectus muscle, it just gives you a little bit more to work with, and then you don't have to take necessarily as much off of abduction either, because I end up seeing a lot of patients who've had too much done to their lateral, and they're super unhappy with the loss of, with the big esotropia in the field of action of the exo Duane's eye.
But you're talking about firing on the medial or on the lateral?
The lateral, the contralateral lateral rectus muscle. You want to, so if my right eye has the exo Duane, no matter what I do to the right eye, it's never going to be fully adducting. So I do an adjustable FODN, resect, like in that case, like, a good, at least like a good 6 millimeters, and then hang it back, 6 or 7 or 8 or 9 or whatever. Try to get it back till it's 12 millimeters at least from the original insertion on the other eye. And the eye still moves, but like I said, it takes some.
However, in my opinion, you have to be very careful with that approach. And you've been one of my mentors, but I will tell you why. If your ipsilateral lateral rectus, the one that you just call large, is still tight and has significant co-contraction still, the procedure that you create on the contralateral lateral rectus will create fixation duress to the medial rectus on the affected eye, which actually will make the medial rectus work harder, which actually going to create more globe retraction and co-contraction of the lateral rectus. So your patient may end up much worse.
Yes, you're potentially right. Or what you really have to watch out for is if the upshoot is innervational and not because of just a tight lateral, because you can usually fix the upshoot with a Y split. But the recession plus the Y split helps with the vertical, and then the and can protect you. But you're right. You always have to be careful operating on the contralateral eye of Duane's patients for inducing weird deviations. I mean, I've corrected a big hypo in the Duane's eye by operating on the medial rectus muscle of the other eye because of previous surgery.
Mm-hmm.
All right. So I guess it's my turn, right?
Yes, it is.
Thank you so much.
Okay.
Last up, but not least, of course, is Dr. Federico Velez from UCLA Stein Eye Institute.
All right, thank you. All right, let's just try here. You can see this, right?
Yes, we can.
Yeah, we see you.
Wait, it says continue to share. I think it's working, right?
Yes.
It is.
Yes.
All right, perfect. All right, so again, thank you very much. And I'm going to present, I have no financial interest. So this is a 30-year-old patient, long-standing diplopia, and you will see why he's complaining in a minute. Okay, here we are. Wait, okay, here. So he doesn't have really a stereo when he's looking straight ahead, but a little bit of gross stereopsis where the head is turned to the left. And a free space prism in the straight ahead. He has a very large angle right exotropia with a right hypertropia, much worse in right gaze, a little bit of isotropia in left gaze, kind of similar to the case that Dr. Capo just presented to us. And he had a left face turn. Here are, I'm sorry that I'm missing one picture, but I couldn't find actually the ones in the middle were taken out of a video. So I'm missing some pictures here, but you can see here, patient has a very significant upshoot, a little bit of a downshoot as well. He cannot really pass the midline with this right eye. And here you can see a video. Hopefully this video is gonna run well. And this is his motility. So I'm gonna stop here. And I don't know, okay, you can see here, okay. Okay, so I'm gonna stop here and just talk about the anomalous vertical movements in Duane syndrome, okay? So just to move here, actually Ramej, I don't know, I think Ramej already left, but if he was here, this is a paper actually published by honored authors, but they honor what Ramej has published on the grade for upshoots. So grading upshoots in Duane syndrome. And also, this is a good graph that I want to bring out because I have found this very interesting. This is from Egypt, where this author, Aurin, he describes how the upshoots can be very abrupt, like you see here in patients with Duane due to misco-innervation, as we have always seen in Duane syndrome. But you can have more gradual upshoots and downshoots, and these ones can be associated to oblique muscle dysfunction. Sorry, this is John. Now, what about this simultaneous contraction of the medial and the lateral rectus? So the initial description of this phenomena was by Alan Scott and Carlos Sousa Diaz. And based on this, there have been multiple publications. And you can see this article by Gunther von Norden, where he actually recommended doing simultaneous recession of both horizontal rectus muscles. I think it's great because you improve the upshoots, but the motility of the patient is definitely not improved. And that's what happened. You can maybe get rid of the upshoots, as you can see here, but there's no better abduction, and there's no better A deduction at all. So there's also this theory that maybe what is happening in upshoots and downshoots is dislocation of the extraocular muscles, pads, or maybe even the globe that is shooting up and shooting down. So based on this, some authors suggested doing fatting operations of both horizontal rectus muscles in patients with Duane syndrome. But then there is this other article by Miller in 1990, where using MRI scan, they actually found that in patients with upshoots, the path of the horizontal rectus muscle was not shifted up and down, was really the shifting of the eye globe because of the compression of both horizontal muscles. So the eye globe was shooting up and shooting down. However, in patients with downshoot, they actually saw an inferior displacement of the path of the lateral rectus muscle. Dr. Diemer and others actually found something interesting in patients with Duane. Is this: there are many other ocular motility abnormalities just in Duane syndrome, including, for example, cranial nerve 4 abnormalities, superior oblique hypoplasia. But what is really interesting is that all muscles can be abnormal except those that are innervated by the inferior division of the cranial nerve 3. I'm going to kind of create a hypothesis in a minute. Why is that? But you can see here a bifurcated lateral rectus muscle. We know that in patients in, and this is a paper by Dr. Hunter on congenital fibrosis of the extraocular muscle, how the superior oblique can be abnormal in patients with uh, uh, CFMO. And also we know that patients with a kind of a similar situation, hypoplastic superior oblique muscles can have an absent fourth nerve palsy, probably the same family of the CCDD disorders. We can have vertical misinnervation, and this is actually something that Kushner and Friedman back in 1997 suggested, that patients can have other misinnervations. For example, the lateral rectus misinnervated with the superior rectus can create, or the inferior rectus can create a pseudo-inferior oblique or superior oblique overaction. What about the inferior oblique? So this is a hypothesis. What if maybe the inferior oblique can be misinnervated in Duane syndrome? And of course, this is the same paper that I mentioned before, how the gradual elevation in adduction upshoot may be more related to an inferior oblique versus this one that is more a misinnervational. Well, Aurin actually published a very nice series of patients with Duane syndrome in whom he performed a myectomy of the inferior oblique in the eye that had the upshoot with significant improvement in great results. This is very interesting because it's similar to what Dr. Hunter put on his patient of the splitting of the lateral using adjustable suture. This is actually a patient that was operated by Dr. Rosenbaum using an adjustable split of the lateral rectus muscle. And we had an opportunity to publish the split lateral rectus recession, even in patients with orthotropia, to improve upshoots and downshoots. And that is a recent publication from this year from another group, basically suggesting the same improvement, upshoots, downshoots, just minimal correction in the primary position. So it's a very safe procedure, and you can actually associate this with medial rectal recession or not, which I don't personally like it because I don't want to kill the entire motility of the patient. And finally, I just want to present this patient who actually I have the opportunity to operate with Dr. Tauscher and other colleagues when I was at Duke. And this is a patient that actually had, sorry, let me just run this video before we go back to the patient. Very severe upshoot, you're going to see severe upshoot, severe downshoot. And so we decided to do for this patient was a lateral rectus split with a belly transposition similar to the Nishira procedure. And that's basically what you actually see over here. The video is going to be running fast, but basically we already did the split. And here you actually see the transposition procedure. And that's where we're doing the belly transposition. And the patient actually improved. I mean, I was really impressed. The deduction is better. The upshoot is better, but it's not completely resolved. You're going to see here, but it's not the same upshoot. So I wonder if this patient needs to have the inferior oblique recession. And finally, I have found, as I mentioned with Dr. Capo's case, these bands of the extraocular muscles more frequently seen in exoduanes. This is a paper by Sener et al. That was published in the Journal of AAPOS. And again, I make reference to this presentation that we did at AAPOS because we know that these bands can be fibrous tissue, collagen, and muscle. So I'm going to go back to the patient, and maybe, Anna, I let you comment on the patient. What would you do on this patient with this severe upshoot? The patient doesn't have a deduction, and this is the position of the eye intraoperatively. He had a hypertropia under general anesthesia.
Yeah, I think this is a great example of when forced duction testing is really going to be helpful to guide some of what you're thinking. My first instinct would definitely be to consider a lateral rectus recession with the Y splitting based on what we experience with the forced duction, the extent of mechanical restriction. I mean, you might even want to consider disinsertion. I think a Y split is probably going to be very helpful, but I'd be curious, Dr. Velez, how you use forced duction to guide the extent of your recession, or how that impacts intraoperatively how much you actually move the muscle.
Great. I'm going to actually mention something that probably we don't teach, but there is something, but of course, in kids, you cannot do it, but there is a forced duction test that is called the reverse forced duction test. It was described by David Romero Apis from Mexico. He was a fellow with Jampolsky, where basically, if you have a patient with Duane syndrome and you try to move the eye because you have limited abduction, just because of the co-contraction. If you ask the patient to look in abduction, you can maybe rotate the eye in adduction better because the lateral rectus is relaxed. But if you try to ask the patient to look in adduction and you try to move the eye in adduction better or more with the forced adduction test, you actually are not going to get better just because your lateral rectus is pulling your eye outward. So just try to ask the patient not to look inward when you're doing a forced adduction test if you're able to do it in an adult awake patient. But intraoperatively, which I think you touched the most important part of this conversation with this case is this. When I disinsert the lateral rectus muscle, I kind of do a dynamic procedure, but I'm a millimetric doctor. I measure where I put it. But what I have found on the lateral rectus when I do the split is that usually the muscle likes to place himself at about 10 millimeters posterior to the insertion. That's what I have found really frequently. So my typical recession when I do a split is I recess 10 millimeters, honestly, regardless of the exotropy in the primary position. And I split the muscle 10 millimeters. So the two halves are separated by 10 millimeters from each other, and they're 10 millimeters posterior to the limbus. So it's almost like a 10 millimeters from the upper and the lower corner of the insertion of the lateral rectus, and you measure 10, that's where I put the halves. But I repeat the forced adduction test intraoperatively as many times as I need just to convince myself that there's no more restriction. And that's how I have found literally many times fibrous bands or accessory extraocular muscles, which is really what I found on this patient. So this patient had a fibrous band that was next to the lateral rectus muscle. So that fibrous band was extending beyond the insertion under the lateral rectus and posterior. I excised it and removed it. And then after that, I also recessed the superior rectus because I felt like this position on the general anesthesia with the eye being in elevation position was not normal. And indeed, the superior rectus was tight as well. So this is the procedure that I did. The patient actually, after 2 years, I saw this patient recently, was very good in the primary position. I don't know if those measurements are really real. I'm going to show you the video. You may say that it's more XT, more ET, but I'm going to show you because that's what we measure in the clinic. Anyway, his depth perception, which is very interesting, showing me that this was a progressive condition, was actually 40 seconds of arc of stereopsis. And when I started, he only had 3,000 seconds of arc. And this is he's now straight in the primary position. You can actually see his motility, his limited abduction, but his upshoot is really gone. So his elevation is relatively good, despite of the recession and of the superior rectus, and he has good down gaze. So yes, he doesn't have the greatest adduction or abduction procedure. I wasn't going to deal honestly with the transposition on this adult patient doing 4 extraocular muscles, although I did one 2 weeks ago where I did touch all rectus muscles in one eye. But this is it. This is the final presentation, and I want to thank you very much for this. I'm done, I guess. Yeah. All right.
Well, thank you all so much for joining us tonight for and spending your evening with us and learning about the complexities in the management of adult Duane syndrome. I want to give a special thanks to all of our panelists here for sharing your very interesting and very difficult cases and for sharing all of your expertise. To our audience, you can see that even though we have the titans of the field here and truly the world experts in adult strabismus and in Duane syndrome, even for them, these cases are very, very challenging and present sometimes multiple different approaches to think about and multiple surgical surgeries that are required to give patients their desired outcomes, knowing that there's limitations. So hopefully this encourages you to try to manage these patients as well, understanding that it's hard for everybody. So thank you all.
Thank you. Good night.
Thank you. Good night.
Thank you very much.